Good morning, everyone. Welcome. This is our talk on the top 10 papers of social emergency medicine. My name is Aisha Khan. I am assistant professor at Stanford, and these are my co-conspirators. You guys can introduce yourselves.
Hi, everyone.
Hey, I'm Quincy Moore. I'm assistant professor at University of Chicago.
And I'm Sachita Shah, associate professor at University of Washington.
Great. So we thought we would start by letting you all know kind of our methodology and our reasons for picking these first few papers. Unfortunately, you can't just type in social emergency medicine into PubMed or Google and have all the things that you want come up. So we actually had to come up with a bunch of terms or topics that we thought were the most important in social emergency medicine. You'll see the list up there. So we searched for those in PubMed and in Google Scholar with the addition of the term "and emergency medicine" to make sure that it was relevant to us. Out of all of the articles we got, we reviewed 42. So we split up these topics and separately reviewed in total 42 articles. And then out of those 42, we ranked 17 of them. So the 17 articles, all three of us read, and we finalized our top 10 articles based on relevance, study size, the quality of analysis, the type of study, the impact, and then the novelty of the study. So after that, we got our top 10, and here they are.
All right, so the first article is Emergency Department-Based Interventions Affecting Social Determinants of Health in the United States, a scoping review by Walter et al. In Academic EM. So the background for this article is, social emergency medicine as a field is, sort of focused on trying to impact negative social determinants of health and sort of broadening the definition of emergency medicine from the traditional biologic model of health into diagnosing and treating social determinants of health. So the objectives of this study was, as social EM as a field is starting to grow, let's evaluate the breadth and scope of interventions affecting social determinants of health. And so I think this is a really nice article to know about because it's sort of a snapshot that maps and categorizes previous studies as we look towards shaping future research. So they use the CDC definition of social determinants of health, and articles had to involve an intervention either in the ED or with participants that were identified via an ED visit. Studies were either with or without a control group, and then the intent was to mitigate a negative effect of social determinants of health on patient outcomes. They performed the search in January of 2020, so it included all articles they found prior to that time. And then abstracts and full articles were reviewed by 2 reviewers, and if there was a discrepancy, they had a 3rd reviewer who would resolve that. Next slide. So they found almost 11,000 abstracts. They read almost 600 papers, and 135 of those articles were eventually included. 78% of the articles reported an intervention as being effective. So, maybe there's some publication bias there, or maybe, we're all just doing great work. And then the articles that they found, they divided into 3 different types of intervention. 18% were provider education initiatives. 26% were disease modification with a social determinant of health focus, and then 60% were directly targeted at social determinants of health. And then within that, they grouped it into 7 different social determinants of health domains. So about a third each were focused on access to care and exposure to violence or crime. 7% was focused on discrimination or group disparities, 2% food insecurity, 3% housing and homelessness, 12% language and literacy, and then 10% socioeconomic disparities and poverty. Next slide. The articles were from 1989 until January of 2020. And if you look at the distribution of the articles, there are many more articles in recent years. So over half of them were published in the past decade, and then over a third of them were published in the last 5 years. About half of them were in EM-specific journals, and then about a third were RCTs. So in terms of take-homes, I mean, I would encourage you to take a look at this article, and because there's a lot there. And this is sort of a quick summary, but it does, in terms of limitations, it leaves out some social determinants of health that we oftentimes think of, like immigration or substance use, legal issues, because they wanted to use that CDC definition. But I think you can tell that there's some specific areas that really have a low volume of articles. There were only 10 articles focused exclusively on discrimination and group disparities, like race, ethnicity, gender. Only 2 articles addressed food security, only 4 articles addressed housing and homelessness. So, I think there's certainly room to grow in those specific areas. And it probably reflects some of the funding that has been available historically for this type of research. But the other take home is that the number of articles are growing, and hopefully that will continue to be a trend that will increase funding and the number of articles that are published in these areas.
Great. Okay. Our next article is Prevalence of Emergency Department Social Risks and Social Needs. So in the current healthcare climate, there's an increasing emphasis that's been placed on social determinants, but screening has largely been focused on the outpatient clinical setting where you can have much longer questionnaires and spend more time. But I think we all agree that the association of adverse social determinants of health and ED health outcomes makes the emergency department a unique opportunity to screen patients. That was part of what we discussed in the consensus conference. And the other part of what we know for sure is that the best way to do this is yet unknown. This study is important because I think it goes one step closer towards being able to come up with best practices for screening questionnaires in the emergency department. By asking the questions, what is the prevalence of social risks and social needs in a large urban ED? What is the relationship between social risk and social need? And what factors are associated with differential responses to social risk and social need? So very quickly, I just wanted to make sure that everybody is aware of the difference between the two. So a social risk is an adverse social condition that is associated with poor health, like housing instability or social isolation, whereas a social need refers to the patient's perception of what their own adverse social determinants of health are and for which they would like help. So it allows for a prioritization of social interventions. This questionnaire distinguishes between the two, and this is actually the questionnaire that they used. So their study method, what they did was initially they had a cross-sectional study that was 48 hours in total. 24 of those shift hours were during the weekend, 24 of them were during the weekday. They started with administering a demographic survey. And then the screening tool, which I showed you previously, is an adapted CMS tool with validated questions from other tools that have been added in 5 domains: housing instability, food insecurity, transportation needs, utility needs, and interpersonal safety. And then additionally, after that, they did a multivariable logistic regression to assess factors that are associated with social risk, social need, or both. And what they found was they were able to approach 614 people. 483 of those were eligible, and 269 participants consented and completed the demographic survey. So of the 269, almost a third reported a social risk, almost a third reported a social need. But very importantly, if you look at table 3, the social risks and social needs were highly associated but didn't completely overlap. Additionally, more than half had multiple domains in which they had either a social risk or social need. In terms of the associations, social need and social risk were associated with lower education, state or public health insurance, Spanish speakers, and non-Hispanic Blacks, whereas social need only was associated with Spanish speakers and non-Hispanic Blacks. So there's some important take homes from this. First of all, this is the first tool that screens across multiple domains. And as we all know, our patients are not unidimensional. So this actually allows intervention and prioritization based on a comprehensive look at all of the needs the patient has. It's short enough to administer in the emergency department. They were able to do this very easily. And what the previously mentioned incomplete overlap underscores the need for screening for both risks and needs, because it allows a patient to focus on their own prioritization of targets. For example, if a patient screens positive for a risk of food insecurity, they may actually determine that what they need when they're asked about needs is transportation, because food bank resources may be great, but what they actually need is transportation to be able to access work, and then they may not have food insecurity. So that would be an example of how those two differentiate. And then additionally, because of the way the associations are, it underscores the importance of screening in different languages, because the non-English speakers were screened very highly on these, and then also providing resources at different education levels. In the future, I think we can look at where and how to administer the tool. Is it best done in the waiting room? Is it best done at registration? Is it best done after the visit? A larger sample size and maybe a different area or different type of practice may be a good place to see if this is translatable.
All right, diving into our next article. So we reviewed several articles on the impact of homelessness on health, and chose this article as we thought it was a well-executed study that addresses the problem of identifying housing instability in the ED by estimating the proportion of ED patients who are housed at their visit, but then who become homeless in the near future after their ED experience. So a little background on the next slide. Housing instability, short of homelessness and including homelessness, is highly prevalent in the ED population. Some studies estimate it to be up to 43%. This is the first study to examine the future homelessness of ED patients who are not currently homeless at their index visit. This was a prospective cohort study at a public teaching hospital in New York, and their data was collected in 2016 and 2017. It was a single urban center, and the researchers compared a baseline patient survey with the New York City Department of Homeless Services CARES database. They estimated that the CARES database captures about 90% of homeless shelter entry. And the CARES database includes the reasons for the homelessness that were divulged at the intake at shelters. So that information was included in the study. The primary outcome was homeless shelter entry within 12 months of the index ED visit. So this next figure shows the timing of homeless shelter entry within the 1 year of their visit. And overall, 5% of the patients enrolled in their study became homeless within 12 months. So that was 96 people out of 1,929 people. And the highest risk was in the first 30 days. They had 37 entries. So this next slide shows a couple of tables from the paper. Table 1 on the left, I know it's small, shows the self-reported reasons for entering shelters, with kind of personal discord being the #1 reason. And table 2 shows demographics of shelter entrants. They found that shelter entrants in their study were predominantly men. They were more often self-identified as non-Hispanic Black patients, and they were insured by Medicaid more often than private insurance. All participants, especially shelter entrants, had other social needs such as food insecurity identified, kind of similar to our last study about social needs and social risk, these often overlap. The limitations of the study, it was a small sample size relatively from a single urban center. They felt that they may have oversampled frequent ED utilizers, and they didn't include unsheltered homelessness, of course, by design, and they were looking at shelter entry. So for folks living outside or in a car, who may be homeless by all social definitions, these were not included in the study. And so this was a smaller proportion in New York, but maybe a higher proportion in more temperate cities, so maybe less applicable. So the take-home points from this study, housing instability is prevalent among ED patients who are housed at their visit, 5% in this study. The characteristics of the patients who are entering shelters from this study differed slightly from the New York City general shelter population. In general, they have more families with children in shelters, and their study had more single men. The majority of the shelter entrants in this study were Black, consistent with known racial disparities in homelessness in the United States. And the ED may be a critical juncture for interventions to prevent homelessness. So towards the future, the idea would be to develop a screening tool to find those most at risk during their ED visit to try to prevent homelessness.
All right. Next article is Disparities in Care, the Role of Race on the Utilization of Physical Restraints in the Emergency Setting by Schnitzer et al. This was an academic EM. So the background for this article, so we know physical restraint use is very common in the ED despite known adverse consequences. And, you know, for every patient that we see, minimizing restraint use should be the goal. You know, techniques like prevention, de-escalation, pharmacologic adjuncts. And there's very limited literature that exists on the role of race in patient restraint use in the emergency department. So this study examined the role of race in physical restraint use at Massachusetts General Hospital. It was a retrospective chart analysis, and they included all adult ED visits over a 2-year period between 2016 and 2018. And they analyzed the associations between race and restraint use and looked at covariates, including sex, insurance, age, diagnosis, and homelessness and violence. Violence, they used a sort of a history of violence. They used sort of a proxy of safety notifications in the EHR. So next slide. So they had 195,000 ED visits over that time period by 120,000 individuals, and 1.4% of those patients had restraints ordered. 2/3 of the patient population was white. 71% of the restraint visits were behavioral, so for some sort of psychiatric indication, then 29% were non-behavioral, so things like altered mental status from medical uses or medical indications, but they lumped those together in their analysis. The effect of race on restraint was significant with a very low p-value there. Specifically, the relative risk for Asian patients versus white was lower risk of restraint use, 0.71, and then the relative risk for Black versus white was elevated, 1.22. And then within that, Black men were more likely than white men with a relative risk of 1.36, and Black women were not more likely than white women. Black patients without a history of violence were more likely than white patients without a history of violence. Relative risk was 1.18. And then you'll see at the bottom there, restraints were also more likely in male patients. Patients with public or no insurance were about 2.3 and 2.4 times more likely. Younger age, which they defined as 50. Substance use diagnoses, psychotic bipolar diagnoses, current homelessness, and then the history of violence that I mentioned. When they looked at the race, they didn't have enough data to analyze all of the covariates at once using a model, and so they adjusted for individual covariates individually, and they found that race was persistently significant when controlling for each of those individually. Next slide. So take homes from this, it's a single center. They used race and ethnicity that was documented in the EHR. So there are some limitations there, self-reported race or, provider perception of race may be different from that. And then, like I said, they lumped together the behavioral and non-behavioral patients. And so that may limit the generalizability a little bit, but I think there are some important take homes here. I think, it's another example of a specific area of practice where we need to examine our own personal biases and also our departmental biases. So making sure that, when you're ordering restraints, is this assessment objective? Have I exhausted the other options that are available to me? And then I think on a more departmental basis, we can all review our processes that are in place to address agitation without using restraints. And that obviously would include, nursing, security, medical director, et cetera, making sure that our processes are appropriate.
Excellent, thank you. All right, so the next thing we're going to talk about are clinical implications of climate change on the U.S. emergency medicine, challenges and opportunities by Sorensen et al. So as you all know, climate change is one of the most pressing existential threats of our time. It is, however, poorly defined in its adverse effects on health burdens, although I think we can all kind of assume that we know that it would affect a health burden. But particularly as an area of emergency medicine focus, it's not very well defined, but we know urgent and emergency presentations, vulnerable populations, and disaster management, which is kind of our wheelhouse, will be most disproportionately burdened by climate change. So although this was an original research, it was the first of its kind paper. It's from the Annals of Emergency Medicine, and it reviews the literature to answer the following questions. What is the contribution of climate change to the rise in emergency department visits over the last 10 years? And what is the impact of health delivery on vulnerable populations? And two, what can emergency medicine do in anticipation of the burden of climate change associated illness and injury? So this paper looked at was a descriptive study that looked at the influences of climate change on emergency medicine, and it particularly focused on disparities and vulnerable populations, which have unique threats from weather-related disasters. And it also offered it was sort of a white paper that offered some novel approaches for clinical intervention and proposes a framework to address risk from within the emergency department. A couple of things that I thought were very well done in this paper was one, for people who may not think that there is a link there, it broke down in this very nice way what climate sensitive diseases were, what the exposure pathway was to causing critical consequences in the emergency department. So this is kind of the like, hey, it does matter, and this is exactly how it works, which I thought was really important. Looked at things like poor air quality, extreme heat, increased allergens, ecological changes, extreme weather events, and disaster events that affect all of these changes. And then it focused on the disproportionate effect on vulnerable populations. So vulnerable populations, in this case, those that are physiologically at risk, so children, older adults, pregnant women, but also, and I think more salient to us in social emergency medicine, how exactly it is that low socioeconomic status affects, it carries a disproportionate amount of the burden from climate change, particularly because they have a higher probability of living in areas that are affected, and they have less resources and less access to medical care and the healthcare system when climate change exposures occur. this slide actually goes over their future recommendations, and it's based on this sort of hopeful thing that they say at the end is like, hey, even though all of these things are increasing, these exposures are worsening, in the end, the health outcomes are going to matter most on what we do to mitigate and adapt and improve our healthcare delivery through this time. And so they came up with 7 key areas of emergency department engagement. The first of these is clinical practice improvements. And if there is one thing that you all do when you go home, I would please urge you to take a look at this table, which has all of the clinical practice improvements that you can do today. So basically, standing at the bedside with a climate-focused lens, these are small changes that you can make in your own practice that will greatly affect patients during climate events and during the times when exposures are the most. The rest of these have more to do with systems. So building resilient emergency departments and healthcare systems. There's actually a US Department of Health and Human Services Sustainable Climate Resilient Healthcare Facilities Toolkit. Sorry, it's a bit of a mouthful, but this toolkit will actually help all of you in your operations folks to make a more resilient emergency department. Third, they go over adaptation and public health engagement. So this would be basically owning up to our place in the healthcare system and using our place in the healthcare system as an early warning system and for epidemiological surveillance. An example of this is the New York City EMS uses is the early warning system for heat-related emergencies. So when things are heating up in New York City, they send the information to their public health entities and hotspots are created. Disaster preparedness, I think we're all very familiar with disaster preparedness ever since 9/11 particularly, having the ability to surge, having the ability to do disaster triage. And then mitigation, which you may or may not realize that 10% of greenhouse gas emissions are due to the healthcare system, which is a huge amount. And there are small things that we can do to reduce our carbon footprint by a large amount. So things as simple as throwing away your trash in a bin that is not marked biohazard, rather than to throw it away in the one that is marked biohazard, even when it's not regular trash, because those are processed very differently. And then, of course, research and education. So the take-home points, the poor health outcomes of climate change can be mitigated by our actions now, even if climate change effect itself can only be affected in a small way. There's a lot that we can do about the poor health outcomes. And again, I would really urge you guys to look at the clinical practice improvements table, because I found that very, very helpful. And those are practical changes that we can make right now.
All right, diving in. So this next study was published in the CDC Morbidity and Mortality Report, so not your typical ED reading, but we included it because it was unique collaboration across many different groups to identify racial disparities in COVID mortality, specifically among American Indian and Alaska Native populations. So next slide. Throughout 2020, health departments and tribal health centers in the IHS suspected that COVID may affect American Indian and Alaska Native populations differently, given disparities from the 2009 H1N1 pandemic. So this was the first collaborative study to look at COVID-related mortality affecting these populations. And to give some perspective, there are 229 distinct tribes just within the Alaska Native Tribal Health Consortium. So doing research in just Alaska alone requires a high degree of collaboration, communication, respect, and trust. This research team managed to pull together researchers from 14 different state departments, health departments, New York City. The states are listed on the right side bullets, and then researchers from the Council of State and Territorial Epidemiologists, as well as 7 different epidemiology, tribal epidemiology centers, and the IHS and the CDC. So a big undertaking. It was a retrospective cohort study from January to June in 2020. And Their primary outcome was to calculate age-adjusted and age-specific mortality rates from COVID of American Indian and Alaska Native patients compared with non-Hispanic white patients. And they specifically used that as a comparison in order to avoid other groups that may have also been having increased mortality due to disparities in health. So they gathered data from a large variety of sources, including mortality and health conditions using death certificates, lab values, case investigations, for their denominators of what the general population was who identified as non-Hispanic white, or the general population in each state who identified as American Indian or Alaska Native. They used census data from 2019 to calculate the age-specific and age-adjusted mortality rates. So on the next slide, there's a figure from the paper that shows their main results. The age-adjusted Alaska Native and American Indian mortality rate was 55.8 deaths per 100,000, and it was 1.8 times higher than among white persons in their study. The rates increased with age with both populations, as we would expect. However, the disparity between the two groups studied was highest among patients who were in the younger age groups, as you can see from this graph. So among the age group 20 to 29, the rate was 10.5 times higher, the death rate. Among the folks who were 30 to 39, the rate was 11.6 times higher. And from 40 to 49, 8.2 times higher in the Alaska Native and American Indian population compared to the rate among white persons. So the next table shows that similar information in tabular form. The ratios that I talked about are on the far right side, and it's sorted by age. So it's kind of a different way to look at that information depending on how you like it. And so the major take home, American Indians and Alaska Natives have experienced a disproportionate infection and death rate from COVID-19. The risk is increased across all age groups, but especially for males in their study, and especially for persons from age 20 to 49, who are generally considered to be kind of the young working age folks in the Alaska Native and American Indian community. These excess risks should be considered for implementing medical countermeasures and prevention activities. Now that this is the second pandemic with the same findings, this information could be used to preemptively support or target or strengthen these health systems that support these at-risk patients.
All right, now we're gonna do a couple opioid related articles. So the first one is Scott Weiner's article in Annals of EM, 1-year mortality of patients after emergency department treatment for non-fatal opioid overdose. So the context for this is, as the opioid epidemic continues, I think we all know many of the highest risk patients are seen in the emergency department, and we have more tools available to us. So things like take-home naloxone, peer recovery coaches, ED buprenorphine, et cetera. So this is sort of asking the question, how high risk are patients that overdose and survive? And should we be doing more than the standard of care, which I think historically for most people has been observing that patient for some period of time, maybe a few hours, and then discharging them home, maybe with some, materials about community resources. So this was a retrospective observational study of patients from 3 different linked statewide Massachusetts data sets, including death records. And they included all patients that were discharged from the ED with a final diagnosis of opioid overdose. Their primary outcome was death from any cause within 1 year of overdose. And then they also looked at the first 30 days after discharge. Next slide. So they had a little over 17,000 patients, 11,500 were discharged from the ED, and so they were eligible for the study. Within that group, 5.5% died within 1 year, 1.1% died within a month, and then 0.25% died within 2 days. Of the 635 deaths at 1 year, 20% of those occurred within a month, and 4.5% occurred within 2 days. So The highest risk period was soon after the ED discharge. And then within those deaths also, 2/3 were documented as related to opioid overdose, although we know that death records are oftentimes limited. 88% of those patients were white, 3% Black, 7% Hispanic, 20% were homeless, and then the median age was 39. So as you might sort of guess, a fairly young patient population that was dying. 49% of the deaths occurred in a hospital, and then 23% were documented as occurring in a private residence. Next slide. So some take homes, there are some limitations to this, that the data sets that they use were not created for research purposes. And so there are going to be some imperfections there, but I think it really drives home the point that there is a significant loss of life continuing to happen with the opioid epidemic. So not only was there a large percentage of patients that died within a short period of time after being seen in the emergency department, but they were very young. The median age was 39. So things like harm reduction, take-home naloxone, counseling your patients on using opioids in the presence of others, so that, if naloxone is needed or they need to call EMS, there's someone there to do it. Those are really important with our patients in the emergency department. And then other interventions that have very promising early research. So starting buprenorphine on patients that are open to that in the emergency department is going to be huge for these patients. And that kind of segues into the next paper, comparative effectiveness of different treatment pathways for opioid use disorder by Wakeman et al. And JAMA Open. So this is not an ED study, but I think it drives home an important point about buprenorphine. So clinical trials have shown that MOUD or MAT, which refers to buprenorphine, methadone, and naltrexone, is more effective than non-pharmacologic treatment of opioid use disorder. And this paper gets at sort of the national landscape of a number of different treatment pathways. So, specific to the emergency department, like I mentioned, recent trials have shown that patients that are started on buprenorphine in the ED are more likely to be in treatment at 7 and 30 days after following up, compared to patients who are given other resources or have brief sort of counseling interventions. So the objective of this study was to look at the effectiveness of 6 different treatment pathways for opioid use disorder, and the outcomes that they used were opioid use disorder recurrence, which they defined as claims for overdose, and then opioid-related acute care, so either ED visits or hospitalizations. So it was a retrospective study, and they reviewed de-identified claims from Optum Labs data warehouse, and it included patients who were 16 years and older with opioid use disorder who had either commercial or Medicare Advantage coverage. Next slide. So the 6 treatment pathways were no treatment, inpatient detox or residential services, intensive behavioral health, and then they broke up MOUD or MAT into buprenorphine or methadone, and then naltrexone, and then the last pathway was non-intensive behavioral health. And they were looking at the, like I mentioned, the overdose and then the serious acute care use at 3 months and then 12 months after the initial treatment. And they controlled for race, ethnicity, sex, insurance type, and medical comorbidities. Next slide. So very large sample size, almost 41,000 patients, mean age of 47, a little over half male, 74% white. The most common treatment pathway was non-intensive behavioral health, followed by inpatient detox, and then buprenorphine or methadone, 4.8% intensive behavioral health, and 2.4% with naltrexone. So at 3 months, 1.7% of the patients had overdosed, and then 1.9% had serious opioid-related acute care. And buprenorphine and methadone was the only treatment pathway that was found to have reduced risk of overdose at both 3 and 12 months. and then also reduced risk of serious opioid-related acute care at both 3 and 12 months. Next slide. So the take-homes, so you know, I guess limitations for this paper, you know, I think it probably underestimates the frequency of recurrence, since it was only using insurance claims. But I think the take home for us is that buprenorphine and methadone is the gold standard for treatment. And I think it's an important message for ED providers because we're putting a lot of energy into developing buprenorphine pathways for our EDs. And it's nice to know that not only is that something that's feasible in the emergency department, but really it's the gold standard for treatment of opioid use disorder, regardless of what setting you're in. So I think a very reassuring message in that regard. And then the other point is we need to secure placement and long-term treatment for these patients when we start them in the ED. So if you look at the treatment group for bup and methadone, the patients that were in treatment for longer did better. So important that we have a place to refer to, and then it's going to be somewhere that has a sustainable path to recovery for them.
Okay, so this next paper we would like to present was completely ED based and published on early data looking at racial and ethnic disparities in COVID-19. We looked at several different studies looking at disparities in COVID outcome, but we chose this one mainly because it was based in the emergency department. The query of the researchers was to examine the racial and ethnic disparities in COVID test positivity, as well as mortality. It was one of the first ED-based studies to publish on these disparities. Despite only having about a month of data, their findings were clear. It was a retrospective cohort study conducted at 3 different sites in the Alameda County Health System, including Highland Hospital. All patients were being tested for COVID were eligible for their study. And they collected data from April 6th to May 4th, so pretty early in the pandemic. Their primary outcome, they looked at test positivity rate by race and ethnicity that were self-reported at ED intake. And then their secondary outcome was to look at ICU stay and 30-day in-hospital mortality. They tested 526 patients for COVID that month in those 3 health systems. 18.1% of those tests were positive, so 95. Of all of those tested, Black patients made up 40.7% of the total tested, but 16.8% of the positive tests, while Latinx patients were 26.4% of those tested, but 58.9% of the positives. This next table focuses on mortality and ICU admission for their patients enrolled. It was a small study. They had 4 patients of their 95 positive patients die, 3 of whom identified as Black and 1 who identified as Asian. The mortality among Black patients was higher than non-Black patients, and this was statistically significant despite the small numbers. So in the discussion, the authors referenced different socioeconomic factors that were maybe associated or maybe would explain the higher test positivity rate among their Latinx patients. They referenced another Bay Area study called the San Francisco Mission Study, in which researchers studied 3,000 patients. They had 62 positive patients who were COVID positive, 95% of whom were Latinx. And the vast majority answered that they were unable to work from home, that they needed to work outside the home, that they made less than $50,000 in household income, and most had households of 3 to 5 people, but a third of their participants had more than 5 folks living in their home, suggesting that all these factors may have played a role in their inability to isolate and their higher exposure to COVID outside the home. So the findings in this study that we're presenting are consistent with other studies showing a higher COVID-19 burden in the Latinx population, even when controlled for access to care, age, medical conditions, social factors, and the site of testing within the study. The median age of the patients who identified as Latinx who were COVID positive was on average 20 years younger than the non-Latinx patients, suggesting that this age cohort might more often be working and more often outside the home. There was a higher unadjusted mortality rate among Black patients who are COVID positive, and that is consistent with other studies from outside the ED that we reviewed as well. So this study suggests that the emergency department as an arena can analyze early disparities in care and outbreaks, or early disparities in outcome and outbreaks, and then be used to sound alarms and hopefully drive early interventions and policy going forward.
Excellent. And that brings us to our last paper, Caring for Emergency Department Patients with Complex Medical, Behavioral Health, and Social Needs by Chase et al. So as you all know, this as a safety net, the ED often sees patients that have complex medical as well as psychosocial comorbidities that are unable to be addressed by ED physicians because of time, maybe because of constraints and resources as well. But addressing social needs and behavioral health and medical needs needs to be integrated into our care of the ED patient. But how do we do so without interrupting flow? So this study asks the question, does an integrated team improve care for psychosocially complex, low medical acuity patients in the emergency department? This was a descriptive study. It was single-centered at San Francisco General Hospital, and it was the first of its kind. So what they did was essentially create an integrated team, and their team included patient navigators, social workers, pharmacists, physician consultants, and specialists in transitional care, substance abuse, and quality improvement. It's very important to note that all of these, almost all of these resources existed even before the study. So they were there, they just weren't working in an integrated manner. The way that you got referral to this integrated team was that the emergency department that decided that you had complex psychosocial needs, and they referred you to this integrated team. The integrated team rounded once a day. And in the time period between October 2017 and March 2020, they saw 3,994 patients. Of those 3,994 patients, they were able to prevent 564 admissions. They were able to prevent 127 readmissions or missions, sorry. And then 1,164 patients were given discharge medications from the team. Additionally, it's important to note that the ED mean length of stay for patients went from 345.8 minutes to 344 minutes, so not much change. The decrease in mean 60-day recidivism went from 3.07 visits to 2.89 visits. And in addition to the admissions and readmissions that they were able to prevent, the team was also able to make complex care plans for 1,046 patients. So these are patients that have care in other places within the San Francisco General Medical Center that was not only taking place in the emergency department. So the take-home points from this is that an integrated care team is able to improve the health of individual patients, and it also has the potential to affect population health. They were able to do it in a financially sustainable way, but just a caveat to that is to realize that they already had all of those resources, and I'm not sure that all hospitals do. Additionally, they're in a city that has a lot of social services, and they were able to leverage that as well as get grants from many of these social service type of organizations. In the future, I think a more robust cost benefit analysis, as well as adding nighttime care into this team might make it a better studied plan to care comprehensively for patients. It's very important that we try to test translatability to other sorts of practice areas. And then also maybe to do a direct cost comparison between care before and care after. I think that if we're able to do those things, we'll be able to carry this model into multiple different kinds of practices, rural, suburban, community hospitals, and not only these large urban academic centers. So with that, we're going to end. We kind of started with where we are in emergency medicine. And I think this last study is really important because it kind of is a nod towards where we want to go, all of us, not only if we practice at a large urban center. So I think we have a few minutes for questions. If you guys want to raise your hand or maybe just put it into the chat. I'll check the chat right now.
It's a pretty small group, so if people want to just pop in and unmute.
Also, like in the chat, there's a lot of links. There's links to all the articles. We're also going to add some like honorable mentions that didn't make this top 10 list, but we thought were really, really great articles. And then additionally, we want to just point out that some of the authors of these articles are in the audience, and we're kind enough to put like a reviewed screening tool, a revised screening tool for the social risk and social need. Maggie put that up. And then is that the only thing? Please feel free to just like jump in and say whatever. If you guys added any other resources, we're really grateful for it.
I thought this was awesome. I think we should make sure that this happens every year, because I think that this is really super, and I had not seen every single one of those, and the ones that I had seen I didn't know in depth. So thank you guys so much for doing the work to do this. One thing I would ask of you guys is, are you guys aware? I know there's a lot of different websites that sort of try to keep track of all these great presentations. What do you guys use to stay up when this sort of comes out? How can the rest of us try to stay up on the latest stuff that's coming out? What do you suggest?
It's challenging. I mean, honestly, at least for me, I assume Sachita and Aisha would say the same thing. For me, it was a really useful way to sort of identify some articles and also learn about lots of new ones. Socialimpact.com does some of that work in terms of trying to sort of amplify new work. I'm not a huge Twitter user, but when I do go on Twitter, there's people who are more active than me who oftentimes will sort of highlight useful articles. So that's what I have.
I'm going to put in a little plug for our journal club now.
Yeah, I was hoping you would.
So it started with those of us on the West Coast, but I think other people have joined in as well. We started a social emergency medicine journal club, which takes place once a month, and we try to highlight 1 or 2 articles. And then about every third journal club, we have one of our fellows present their works in progress in social emergency medicine. I have found that it is the #1 way that I stay abreast of what's going on. It's been really good to have people like Brina at UCLA, Sachita at University of Washington, and then me kind of in the middle in the Bay Area. And then Himmel was able to join us for this last paper that we did. That's where we got a lot of these sources. And even if you can't join the journal club, it's a Google group. So all of the articles are categorized, like they stay there for what we do every month. So we invite any and all of you to participate in that. You can email me, or you can we get a link to the journal club? If you email me, I'll add you to the Google group. I think that is the easiest way. I'll just put my email here. It's also, if you guys do email me, it would be really great if you had a Gmail account rather than your university accounts, because it's just easier that way.
Yeah, and it started out as a place where fellows in social emergency medicine could present, but we don't have a social emergency medicine fellowship at University of Washington. We have a global health fellowship, and so we're just participating. Our residents participate, the ones that are interested, and so it's an open group, and the more the merrier. So it's a great way for us as faculty to learn from the fellows and residents when they bring up articles that they want to discuss. So thanks, Elizabeth, for that question.
Does anyone else have questions? We're happy to refer you to the authors that are in the audience to answer their papers.
The only other thing I would mention, of course, is that there is the social emergency medicine interest group meeting this afternoon. So hopefully everyone can make it. And I think I have the cut and paste from yesterday or from 2 days ago. So I will cut and paste that and put that in the chat so everyone has that.
And that, what time is that meeting?
3 p.m. Central. So
Central.
3 p.m. Central.
Okay.
All right. If anybody's celebrating today, I want to wish you an Eid Mubarak. Yesterday was the last day of Ramadan, and I'm going to go eat some food with my family now.
Thanks,
Bye,
everybody.
Thank you so much.
Thanks, everybody.
Great job, guys. Thank you.